Hello everyone and welcome to 2025 Global Public Health Week, an initiative of the World Federation of Public Health Association. My name is Marta Lomazzi and I'm the Chief Operating Officer of the World Federation of Public Health Association. I'm really pleased to be here today with you to briefly introduce one of the key webinars we ran last year on HPV gender-neutral vaccination. It's an extract with a specific focus on a country that is doing a lot on HPV, Liberia. We will listen from Dr. Adolphus Clarke about what happened in his country from the pilot project in 2026 targeting girls around 10 years old up to the introduction of the single dose for girls in 2025. And also let's listen to his reflection about ways to move towards a gender-neutral vaccination for HPV to protect both girls and boys and the community as a whole.
Thank you, Marta and Maria. Let me say good afternoon, good morning, good evening to all, depending on your time zone. It's a pleasure being on this platform at this point in time, joining this forum to share Liberia experience with respect to HPV vaccination and how we can pivot towards a more inclusive vaccination strategy that looks at both boys and girls, irrespective of the age bracket. That being said, this is the title of my presentation. We are going to talk HPV from a gender-neutral perspective. Are we on course as a country? If not, what are the plans? But by and large, we want to focus on enhancing public health through a more inclusive vaccination strategy. The next slide, please. So, since we weren't given prescribed presentation template, what I thought given the time limit for this webinar is to focus on 4 critical pieces that looks at HPV introduction in Liberia, the genesis. We talked about the economic implications of gender-neutral HPV vaccination, challenges in implementing a gender-neutral HPV vaccination, conclusion, and then future direction. The next slide, please. Okay, so before then, I'd just like to run through a few bullets in terms of intro. We all know that HPV, in terms of acronym, stands for the human papillomavirus. And this is a disease that's transmitted sexually. That's a fact that we know. And we know that then in the course of progression, it can lead to cancer, to include cervical cancer, because there are other HPV-related infections that can also cause anal cancer. It could cause penile cancer. There are different forms that could result into. Thankfully, we have a proven preventive measure, which is the HPV vaccine, that not only prevents cervical cancer, but also helps in the prevention of other HPV-related infection. And then, of course, the importance of gender-neutral vaccination to protect both male and females. Next slide. So the story of HPV started far back in Liberia, as far back as 2016. But just to give a more recent or current stats in terms of what the situation looks like, the WHO 2020 and GlobalCon 2020 report still show that in Liberia, cervical cancer ranked as the #1 cause of cancer mortality in female and as the #1 of all cancer mortalities in Liberia. So this is a disease of concern, and we need to roll up our sleeves and see how we ensure that we can defeat this. So that being said, the story of HPV started like other countries with the demonstration. So Liberia took in the HPV demonstration process in 2016. at which time, based on the restriction, we had to focus on 2 counties, Bunk and Nimat, and we were looking at girls 10 years that were in and out of school based on vaccine availability and other restrictions prescribed within the demonstration guidelines. We were successful in carrying out the demonstration and had hoped to introduce the vaccine in 2018, but we had some delays as a country, and it was routinized on the 25th of November 2019. So HPV vaccine now is part of the routine vaccination program that is administered across the 15 counties in Liberia, and is currently administered to girls 9 years that are in and out of schools in Liberia. We made determination for 9 years, one, because of the stock available, two, the cost implication, and then three, in Liberia, it is tradition that a 9 years old girl child may not be involved into sexual life, and so we decided to start with the age before sexual life, and so a decision was reached to focus on 9 years girls that are in and out of school in Liberia. As of 2023, our administrative coverage for HPV stood at 91% for the first dose and 45% for the second dose. So it tells you that we are still struggling with HPV dose 2. However, based on new information regarding the effectiveness of a single dose HPV as compared to the 2 doses, the country is in the process of having a shift from a 2-dose HPV vaccination schedule to a single dose HPV vaccination schedule. So what our focus would be to sustain whatever gains we've made with the first dose, and in those counties that are lagging, how can we build the courage and sustain it as well? And we hope that the switch process will actually take place in 2025, January. Next slide, please. Okay, so what are some of the economic implications that we think we need to consider when talking about a gender-neutral HPV vaccination? For instance, we want to look at the healthcare cost, the cost around treatment, especially in a low-income country. We know that the cost in a low-income country becomes almost unbearable for the patient and even for the families. So we think that having HPV vaccine being administered not only to girls, but to boys also help a parent and a caregiver, and by extension, the health system, in terms of cost savings and redirecting or reallocating sales savings to other critical health system areas that will need urgent budgetary support. So that's one economic benefit that we see there. We also see that it leads to increased productivity, because in the final analysis, we're going to have a healthy youthful population that will contribute substantially to the overall economic growth of the country. So take, for instance, in Liberia, persons between the ages of 0 to 17 years account for 40.1% of the total population, and those that are between 18 to 34 years account for 33.5%. So it tells you about 73 or more percent of our population, they appear to be youthful. So having a very youthful population and focusing on ensuring that they are protected brings economic dividend to the economy and to the country by extension. So we think that that's another benefit that we need to look at if they are healthy and they are protected. And so those who are into the discipline of health will also contribute to the health system by extension, because they will be healthy, they will be able to go to work, and they will be able to protect as many persons or clients that they have to treat within the course of their duties. And then, of course, the issue of equity. We see a gender-neutral vaccine promote health equity by ensuring that both boys and girls are protected, because from the get-go, we struggle with this question from caregivers: why are we only vaccinating girls and not boys of same age? So that also served at some point in time as a breeding ground for mis and disinformation. People felt that the HPV vaccine, when we started the demonstration, was intended to make the girl child get pregnant, it was intended to do something evil to them. So there was a lot of myth around this, but thankfully now that there is this quest to ensure that countries rethink their HPV vaccination strategy to be more inclusive, to consider their male counterpart or boys in this case. We know that in UK, for instance, in Canada, in the US, boys are receiving HPV vaccine as well. So how can we ensure that HPV-related infection can also be prevented in male counterparts? So these are some of the things that we thought to consider as we move along. The next slide, please. So of course, the cost effectiveness, it is efficient use of resources can attract international funding and support. So for instance, if we are able to vaccinate both male and female within our vaccination program for HPV and able to demonstrate cost efficiency, we thereby reducing wastage or damaging of vaccine or expiry because of the difference of the dropout we have between those one and those two. As you saw, 91 and 45 is substantial, approximately 46 percentage point difference. So what that means is that if those people who did not receive that those two don't show up and you have a very short shelf life vaccine, the tendency for it to get expired is very high without it being fully utilized. So in that instant case, we will be inefficiently utilizing resources with respect to the vaccine itself and other supplies. So we think that if we are able to demonstrate efficiency around available resources, it helps to attract international support and then also bring in additional resources that can help to enhance the health system, by extension, the economy. And this can also lead to long-term health outcomes that includes reduction in cervical cancer rates within country, can also lead to economic stability because you wouldn't have people being sick. You have a more healthier population that can contribute towards the growth of the economy in a more productive way, as opposed to having more sick people. And there is so much being done to get them back up to their feet. The next slide. So what are some of the challenges that we envisage? We recognize the issue of cultural and social norms. I mean, we are in a traditional country, and so we must recognize that the settings will differ from county to county, from country to country, and from district to district, from communities to communities. So we recognize that, and it's something that we have to work on going forward if we have to bring on board male counterparts to receive HPV, because then the question comes back at us, why you started to vaccinate only females and now you're adding the male counterparts. So we need to recognize all of these things. We also need to take into account community resistance, because from the get-go, we told them that we're only vaccinating males. Suddenly now we're talking about bringing males when we're only vaccinating females. So what has changed? How can we use available information to reinforce the importance of the vaccine and why they need to trust the system to have their male child 9 years or 9 to 13 years being vaccinated with HPV. So these are all challenges that we anticipate and look forward to working with our communication folks or folks in social behavior change to see how messages can be crafted more positively to address these anticipated challenges. Of course, the issue of resource constraint, bringing on board the male counterpart brings on board additional doses. And the fact that HPV vaccine is one of those co-funded vaccines through Gavi, what that means is that the country's counterpart funding mechanism will also increase. And so it's something that has to be further discussed with the Ministry of Finance to be able to mobilize the additional resources to support its co-financing contribution. Yes, certainly there will be concern around infrastructure, coaching equipment, vaccine carrier cool boxes, refrigerators. So these are all things that we have to consider and see how we can invest in them if we have to consider bringing on board the meal counterparts. And then, of course, our supply chain system, you have broken or aged coaching equipment, they have to be replaced. Some of those ones that are repairable have to be repaired. Vehicles that are broken have to either be repaired and or replaced. And then, of course, ensure that there is availability of vaccine at all point in time to avert stock out of the vaccine, because it will also serve as demotivation. If people are mobilized to show up to a health facility and having worked 2 hours or an hour 30 minutes only to know that the vaccine is not available, it serves as demotivation. So these are all challenges in terms of operation that we need to recognize and see how we can develop practical strategies to address those before we have to switch. The next slide, please. And now, of course, there is concern around policy and governance. We need to ensure now that our immunization policy is revised to support that, because the current policy that was updated 2022 still reflects the administration of HPV vaccine to girls 9 years. And so bringing on board male counterpart means that that policy has to be relooked at. So it's a challenge that we see. So there has to be a clear policy framework that supports the gender neutral vaccination prior to its implementation, because that would be our reliance. A parent could just ask you, what is it within your policy that supports you vaccinating my 9 years old boy child? So it also has to be supported by that. There has to be awareness. Of course, I've talked about that. The communities will have to be engaged. Awareness campaign has to go on within communities, within schools, to ensure that the shift is more positive, so that we don't have any resistance or non-compliance or hesitancy. So the awareness and education campaign has to be very strong. The other thing we recognize is that the vaccine was introduced November 25th, 2019. And we know the story about March 16, 2020, Liberia reported COVID. The first case of COVID on March 16, 2020, there were closure of schools. So that led us to missing out on good number of girls within the gray age bracket, and these girls have not been captured yet. We are hoping to do a HPV vaccine next year, at which time we'll be vaccinating girls 9 to 14 years. So we hope that those girls who were missed out on can also be considered. With the issue now of gender neutral vaccination, we are going to further discuss to see whether the HPV vaccination campaign can also bring on board male counterparts, and what that implication would be in terms of vaccine availability and operational cost. So it's something that we'll discuss with Gabby and see the possibility along with other partners, how doable or feasible that is. And then, of course, the issue of equity and access. We know that there are communities that are beyond 5 kilometers. We know that there are communities that are beyond 10 kilometers. How do we ensure that, irrespective of their geographical positioning, they have access to life-saving HPV vaccine, both the male counterpart and the female counterpart? So this is something that we have to ensure that happens. But again, we recognize this as a challenge, because some of the areas in terms of access are very, very challenging. Some of them, the roads are horrible. Cars can go. If you walk in footpath, you have to walk 3, 4, 5 hours. But with commitment, we think that these challenges can be overcome. So it's something that we want to strategize as a country, not using a one-size-fits-all approach, but focusing on counter-specific approach. What works in counter A would be the approach we think that should be developed to address whatever challenge or challenges we've identified. So these are some of the things we want to do, but we want to brace ourselves to the reality that there will be challenges, or there are challenges, and if we are able to recognize those challenges, then the possibility of solution is imminent, rather than thinking that it's just going to be a free ride for us to transition. The next slide, please. So in conclusion, we think that we need to enhance our public health and reduce the burden of HPV by vaccinating both male and female. That's one thing we are sure of. If we are able to vaccinate both male and female, the tendency of reduction in terms of HPV burden will be very high, because we know that there are other HPV-related infection in males, like I talked about penile cancer, talked about anal cancer, oral pharyngeal cancer. There are different other forms that the male counterpart could be confronted with. And so if the cause of the infection is HPV, vaccinating that male child also helps in reducing the burden of that disease. The other thing is that there will be greater herd immunity at teen, because the more we are able to protect, the greater the herd immunity. And so once we are able to reach more targeted beneficiaries within the community, the more resistant the community will be to an infection because of herd immunity. And so even if there is an outbreak or case, that community wouldn't panic because of the herd immunity profile or rate. And we think that this will help to reduce transmission and, of course, promote equity from a gender perspective within the healthcare system. The next slide. So what are our future directions? So I'm just going to take the broad bullets. So one, like I said, we need to strengthen the policy framework. So before the switch, there has to be a clear policy framework. So our immunization policy, we have to speak to our actions that we want to implement. So there has to be a review or revision of the existing policy to reflect where our policy shift or change that we want within the immunization program. We have to ensure that that framework is aligned both with international guidelines and best practices, so that we are not doing something totally different from what the globe is doing. So that platform has to be there. And we need to ensure that within our national schedule, vaccination schedule, there is that shift. So the first thing that has to happen, we have to strengthen the policy framework. The second thing, we have to secure funding in terms of sustainability. So we need to advocate with the national government for additional budgetary support, because bringing on board the male counterpart indicates that we are bringing on board additional financial burden to the government. And we all know that the government has got multiple priorities. So the sooner we are able to engage them to be able to commit their resources, the better for us. But also the government also need to interact with our donor partners to see how they too can complement government support within that respect. The other thing, from a sustainable mechanism perspective, we need to ensure that there is a dedicated trust fund for immunization in the future that helps to address some of these operational challenges or issues around vaccination program. Next slide. Of course, we think that monitoring, evaluation, accountability, and learning plays a very critical role. We know that then after the introduction of a new vaccine, we do post-introduction evaluation. Now, we think that what is also important is that as we bring on board a different age bracket, there has to be an evaluation that, or a research that informs policy decision going forward. How did the community respond to the inclusion of male counterpart for HPV vaccine? What lessons can we learn from that to inform other future situation within the vaccination program? So that's something we think is also very critical. So male plays a very critical component of our future direction with respect to not just the inclusion of male counterpart for HPV vaccine, but the vaccination program in general. And of course, the last component has to do with community engagement education. We think this is a very critical piece. In the absence of having a robust awareness campaign on the importance of gender-neutral vaccination or the inclusion of male counterpart for HPV, the tendency of hesitancy, the tendency for misinformation, the tendency for disinformation becomes very high, and that could lead to low uptake of the vaccine after substantial investment. So we think that these four components are critical if we have to succeed in terms of our future directions. Next slide. Yes, so thank you in the different vernaculars. Thank you.